So you'll see there that, our speaker series is a digital series, and we've been doing this 3 times a month. We've really expanded. And like Erin said, sometimes adding even extra. And it would not be possible without our friends from West Pharma, who is our presenting sponsor, as well as our supporting sponsors, who is Daiichi Sankyo, Merck, and Lilly. So we cannot thank them enough. We have well over 40 events a year, and all of that is possible from their support. So our cup is full, and we are most grateful.
Wonderful.
I did see that Dr. Rothman went in and out, so let's see if she is hearing. She had some trouble with her audio as well.
Yep. Dr. Rothman, you want to give us a try? I'm going to ask you to unmute. There we go.
And Dr. Rothman, you might want to look down at your mute button. There's an arrow there. And if you look at that, just make sure you have the same system. I don't know if you have AirPods in, but sometimes that gets wonky. So you may want to try and just put them away if it's just not connecting, or just make sure that they are the same system. Same as system is what you select for speaker and microphone.
I think we can maybe hear her. Dr. Rothman, you want to say something? Maybe she can't hear.
She can't hear us. Yeah.
Okay. Okay.
She's going back out and in again.
Yeah. We've been there, right? We've done this enough that we've all been there.
Absolutely. Absolutely.
Perfectly fine.
For those of you that are in the Philadelphia area that are joining us this evening, that is our hometown. And we are getting ready to have one of our largest signature events. It is a gymnastics event, actually. If you get on our website, sometimes people say, what's the connection with gymnastics? How did that all come to be? And that was really my background. I was a gymnastics coach back in the day for 27 years and did gymnastics. And it really was an area I knew well. So when I started a nonprofit, we had to raise funds, and that's how we did it. So this little gymnastics meet is now at the Pennsylvania Convention Center with 4,000 athletes and about 12,000 in attendance. And that is coming up the 17th and 19th. So if you are around the Philadelphia area, you want to come by and say hi to Erin and I, our whole staff will be there, along with a lot of incredible young athletes, and all uniting to actually help support all of you and the 5,000 plus that we are serving this year. So that is happening on the 17th and the 19th. Watch our feeds, watch our emails. We always like to report on that. And it's just such a joyful 3-day event. We call it our pink camp because we get so many darn steps in all over that convention center.
Lots of steps.
Definitely 22,000.
Easy.
Is, average. Yeah. Yeah. All right, Dr. Rothman, can you hear us okay now?
I joined from my phone. I have no idea what's going on my computer, but
that's working well.
I apologize.
Please don't worry. Erin and I have been there before. Please don't worry.
So many times. Yeah. Do not worry.
Yeah. Well, Erin, I say let's get started. Would you like to do an introduction? I'll put Dr. Rothman up there front and center.
Please do. Yep. And Dr. Rothman, I'll have to go through your slides, but we just want to share because we're so happy to have you also in our Philadelphia area. So Dr. Jami Rothman is Assistant Professor of Clinical Surgery in the Division of Endocrine and Oncology Surgery at the University of Pennsylvania. She's received her undergraduate degree from Cornell and her Master of Science in Public Health from Harvard. While at Harvard, she studied the impact of racism and poverty on cancer prevention in low-income populations, as well as the intertwining of provider and systems-level interventions to measure their effects on cancer screening and early detection. She went on to receive her medical degree from the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo, where she also completed her general surgery residency. She completed her fellowship in breast surgical oncology at the University of California, San Francisco, where she trained in some of the most innovative operative techniques including nipple-sparing mastectomies, tumor and sentinel node localization, intraoperative radiation therapy, and oncoplastic surgery. So please join us as we welcome Dr. Jami Rothman with us.
Wonderful.
Thank you so much
Thank you,
for
Dr.
having me.
Rothman.
It is an honor to be here, so I appreciate the invitation. If at any point while I'm presenting you're having trouble hearing me or you want to interject with questions, please feel free to interrupt. I think Erin's going to go through my slides for me, so I don't know if you have the slides up.
I do, and we will, there you go, play from start.
You can go to the next slide.
Those are mine, Erin. You might want to.
Oh,
Yeah, I think mine had a blue background.
okay. We're here we go.
Nothing we can't juggle. No worries.
I have everything.
Pop the next one in.
Okay. Bear with
Erin,
me.
you were quick too. You got right on that full screen.
I wanted to have both of them up in the event someone needed support, and I helped the wrong person. Here we go. Sorry about that.
All right.
Perfect.
I need all the support I can get. So you can go ahead and advance to the first slide. So before I talk about cording, otherwise referred to as axillary web syndrome, I wanted to briefly go over the two types of axillary lymph node surgery that we as surgeons perform for patients who've been diagnosed with breast cancer, since I'll be making reference to these specific surgeries throughout the presentation. Thankfully, we're working very hard on de-escalating care and really coming up with a very precise approach in terms of systemic therapy as well as surgical management. So less is more in a lot of cases. We used to think that doing a bigger operation would always lead to a better outcome, and now we know that that's not the case, especially when it comes to the lymph node surgery that we do. So for most women who come in with a newly diagnosed breast cancer, when we take them to surgery to do their definitive cancer operation, we typically perform what's referred to as a sentinel lymph node biopsy. So most women have anywhere between 40 and 70 lymph nodes under the arm that are draining the breast. However, out of this huge number, there's typically anywhere between 1 and 4 that are directly communicating with the breast. So if we can selectively find these few lymph nodes that are directly draining the breast and target those, remove them, and look at them under the microscope, then we can figure out, whether any of the other lymph nodes beyond those are involved while doing a very small operation. So technically what we do, a woman goes to sleep in the operating room, I inject a tracer into the breast, I massage it into the breast, and it travels through the lymphatic channels of the breast tissue to reach the lymph nodes that are directly communicating with the breast. I then have a probe that I use in the operating room that can detect which lymph nodes have the tracer. It makes a beeping noise when it finds a lymph node that has picked up the tracer. So again, everybody's different. I might have 1 lymph node that drains my breast. Some people might have 3 or 4. I don't know until I get into the operating room how many lymph nodes I'm going to be removing. But compared to the alternative surgery that we used to do for almost everybody, it's a much smaller operation, it's a much shorter operation, and there's far less trauma to the tissue, including the lymphatics, the nerves, and the blood vessels. The larger operation that I keep making reference to is what we refer to as an axillary lymph node dissection. Here, the landmarks are really anatomic, so we're aiming to remove all the tissue between 2 very specific nerves and the axillary vessels. So it's a huge amount of tissue that we're taking. Everybody's different. For some women, this tissue might contain 15 lymph nodes. Other women, it might contain 40 plus lymph nodes. But as you can imagine, there's a lot of trauma to the surrounding tissue and a lot of risk that comes with that, unfortunately. So you can move on to the next slide. Risks specific to axillary lymph node surgery, of course, pain, both acute and chronic, is one of the side effects of axillary surgery. Sensory disorders, swelling of the armpit or the axilla itself, weakness of the arm or shoulder stiffness resulting in loss of mobility, lymphedema over the long term, and then of course what we're going to be speaking about tonight is this axillary web syndrome, which is otherwise referred to as cording, lymphatic cording, or fibrous banding. Axillary Webb syndrome was actually first coined in this 2001 landmark paper by a gentleman by the name of Dr. Alex Moskowitz. He's a surgical oncologist who noticed over time that many of his patients who'd undergone axillary lymph node dissection were developing this cording phenomenon as part of their sort of immediate post-op recovery. So he went back and he analyzed data for 750 of his patients who underwent axillary lymph node dissection from 1980 to 1996. And he found that 44 of them had developed these axillary nodules along with limited limb movement, especially when it came to shoulder abduction or extending the shoulder away from the body. Typically, this was observed 1 to 8 weeks following surgery. You can go to the next slide. So as he defined it, axillary Webb syndrome is a post-axillary node dissection syndrome that is seen in a subset of breast cancer patients that's characterized by pain radiating from the axilla all the way down the arm, limitation to shoulder range of motion, and then an axillary web of tissue that's most obvious when a patient extends their arm away from the body. He felt that it was a self-limited condition, meaning that it would resolve on its own with no long-term sequela. Typically, it develops between 1 and 8 weeks, and in his experience, it would resolve by 2 to 3 months after surgery. You can go on to the next slide. These are just some examples as to what cording looks like. So in the picture on the left, you see a woman whose arm is extended up over her head. And you can see, I can't use my pointer here, but you can see these sort of very thick bands, like this webbing that extends exactly from kind of the base of her armpit or her axilla and goes down the arm. It might be a little more obvious in the patient on the right. She's undergone a simple mastectomy and has a couple very obvious bands of fibrous tissue. They almost look like marionette strings on a puppet. You can go on to the next slide. These are two additional pictures. Typically, when we think of cording, we think of these bands directly under the axilla, but they can actually extend all the way down the arm. So in these patients, you can see the antecubital fossa, which is the inside of the elbow. The patient on the left, she has these very thin fibrous bands that are crossing that area. And the patient on the right, you can see the cord starting from her upper arm. It sort of disappears and then it reappears on the inside of her elbow and extends down into the forearm. So when doing an exam, we obviously want to pay attention to the entirety of the arm. You can go on to the next slide. Cording, however, is very much an evolving definition. And unfortunately, there's a lack of gold standard when it comes to defining what cording is. And that can be problematic in a number of ways, which I'll get into in the next slide. Typically now you'll see it defined as a web of axillary skin that overlies one or more cords. The cords might be referred to as ropes, bands, tendons, even violin strings. They can be compared to taut wires. The cording can extend down through the antecubital fossa. Again, that's the inside of the elbow, and go into the forearm and the wrist. Typically, it occurs within the first 8 weeks after surgery, and most often the symptoms do resolve within 12 weeks of the operation. But the longer we're following patients out, the more we're discovering that this really can turn into a chronic condition. Some studies have reported the appearance or persistence well beyond that 12-week window, as late as 2 years following surgery. And other studies have shown that the cording can actually recur after the initial resolution. So it might resolve in some patients and then reappear, weeks to months to years later. You can go on to the next slide. So this table here was taken out of a recent paper that was a meta-analysis of several different studies on cording. So essentially what this paper did is it collected various studies that looked at cording in breast cancer patients specifically, and compared each of those studies in terms of incidence or the likelihood that specific patients were developing cording. So if you pay attention to the column right in the middle, those percentages are the percentage of patients in each individual study that went on to develop cording during the period of observation. You really see this huge range. I mean, the first study, only 6% of patients of the women who were being followed in the study went on to develop cording. And in the study at the bottom, 91% of women were observed to develop cording. So then the question is, why do we have such a wide range? And I think the most important sort of contributor to this is whether or not cording was specifically looked for on post-op exam. Many surgeons won't look for cording. And so if it's not documented in the chart and patients don't complain about it, it would certainly go as undiagnosed and not be included in these studies. The incidence is also very dependent on the type of surgery and the length of follow-up, which of course is very variable between these different studies. Two recent studies that looked at patients from a prospective basis, and this is important because rather than sort of looking at old data sets where there's minimal control over how the surgeons or whoever was doing the post-op exam recorded things, prospective studies are following patients in real time, and so you can have a lot of control over the parameters and who you're including and how you're including them. So these two prospective studies include evaluations of post-op breast cancer patients and demonstrated that the actual value in terms of incidence likely lies sort of smack in the middle of the 6% to 91%. One study found that 50% of women had cording 18 months following their breast cancer surgery. The other study showed that 51% of patients who were enrolled had developed cording by 8 weeks following surgery. You can go on to the next slide. In terms of pathogenesis, so how does cording develop? Unfortunately, our data is pretty limited. There's a lot of speculation as to how this occurs, but unfortunately, we still don't have a definitive answer, which is really problematic because we can't figure out sort of exactly the pathogenesis behind this, and it's really tough to come up with definitive solutions for how to treat patients or how to prevent this from even happening to begin with. So that 2001 paper, that landmark paper that first defined cording, basically, thought that the pathophysiology involved clipping the veins and the lymphatic channels under the arm that resulted in interruption of flow of both the blood and the lymphatic tissue. That interruption of flow then led to thrombosis, inflammation, and sort of scarring on the inside of the vessels and the lymphatic channels. And that scarring from the inside led to this transformation into these fibrotic bands, otherwise referred to as cords. You can go on to the next slide. In sort of reality, there's a lot more subtlety to it. So yes, venous clipping and lymph node resection certainly interrupt flow, but a lot of that is dependent on small things like patient positioning in the operating room, which is actually a very big thing. The amount of tissue retraction that we do during surgery. So obviously that's very different between someone who's having a large lymph node dissection versus someone who thankfully is having a smaller sentinel lymph node biopsy. Yes, thrombosis, inflammation, and fibrosis still occur, but a lot of that is also related to sort of the microbiological factors associated with this, including hypercoagulability or the increased propensity to clot following surgery, or even release of chemicals like tissue factor from sort of the tissue that we're cutting through, which leads to increased scarring. Yes, we still know that ultimately there's this transformation into fibrotic bands. The thought is actually that nowadays there's more speculation that it's less to do with the vessels than it is the lymphatics themselves. So now the theory has more become that it's outflow obstruction induced by removal of the lymphatics, and that vessel injury has less to do with it. But again, unfortunately, the jury is still out and we don't quite know. You can go on to the next slide. This is just a medical illustration of sort of what we sort of expect it to look like under the skin. The small, in that sort of area that's magnified, you can see normal lymphatic channels, which are the solid green. The ones adjacent to it, which have turned into cords underneath the skin, those are sort of those scarred, fibrosed lymphatics that have been cut, that have turned into these fibrotic bands under the skin. You can go on to the next slide. So in terms of signs and symptoms, cording typically presents as a tight, millimeter-wide, linear, singular cord or multiple cords of tissue that are directly under the skin in the axilla. Typically, they will extend down the inside of the upper arm, but you can actually also see them moving in the opposite direction along the outside of the chest wall. Cords become more visible or able to be felt when the arm is fully straightened and then extended away from the body. But it's important to note that not all cords are visible and not all cords are palpable. And so there is unfortunately a lot of variability on physical exam just due to factors, that are not only inherent to the person doing the exam, but the patient themselves. When the arm is not in proper position, tension is taken off the cord and the cord may not be evident. And so there is, a best way of doing an exam, which I'll get into in a couple of slides to make sure that we're not missing things. Typically at the onset of cording, patients will experience restricted upper extremity movement, typically during shoulder abduction or moving the shoulder, moving the arm away from the body. They'll have pain or discomfort whenever the arm movement increases the tension on the cord. But unfortunately, patients who haven't been educated about cording may be unaware that this is due to cording. In my experience, patients in whom the diagnosis was delayed often believed that this was just a normal part of their post-op recovery, unfortunately. The full gamut of patient symptoms is very dependent on the cord location, however. Some patients may be unable to extend their elbow because the cord extends across the inside of the elbow. In these cases, patients will typically present to clinic sort of holding their arm across their trunk, almost as if it's in a sling because it's so uncomfortable to extend their arm straight. Some patients who have less rigid or shorter cords may have minimal cord tension and minimal symptoms until they approach full extension of the arm. In my experience, they frequently describe arm movement that just feels different or not normal, but it's really hard for them to articulate what it feels like. Typically, it goes ignored over several months or several years, and then they sort of learn to live with it until their symptoms later develop into chronic shoulder mobility and strength issues, unfortunately. You can go on to the next slide. The risk factors for development of cording are really interesting, and we don't seem to understand the etiology of all of them. So whereas being overweight or obese is actually a well-known risk factor for developing lymphedema after breast cancer surgery, it actually appears that the reverse is actually true for developing cording. In other words, thinner women are actually at greater risk. In a prospective study that looked at 85 women with breast cancer, the average BMI for those who developed cording was 23 as compared to a BMI of 26 for those who did not develop cording. Another study of 116 women, the average BMI for those with cording was 25 compared to 29 for those without. We don't exactly know why there's a relationship between BMI and cording. There's a couple theories that might explain this. It might be that excess subcutaneous fat in obese patients might prevent the development of adhesions forming between the skin and the underlying tissue. And another explanation might be that the fibrotic bands of cording are less visible and less easy to feel in women who are obese, as sort of the increased adipose tissue may sort of conceal them and hinder our exam. Younger age has also been shown to be a risk factor for developing cording. In 4 prospective studies, they showed that younger women with breast cancer typically have a lower BMI. So it's actually been speculated that perhaps age and BMI are interrelated here, and then it's not age in and of itself. I think the most important risk factors here, which I should have bolded because this is really the primary risk factor, is the number of nose removed and the extent of axillary surgery. Again, this really goes into play sort of the difference between doing a smaller sentinel lymph node biopsy as compared to a larger axillary lymph node dissection. There are truly a lot of benefits to be gained from doing a less invasive operation, but cording is certainly one of them. And then interestingly, hypertension has actually been found to be related to the development of cording. We don't quite know why high blood pressure might be related. There's thoughts that the high blood pressure or the drugs that are used for treatment can actually interfere with the lymphatic flow and somehow increases the frequency or the appearance of cords. But more studies are needed to try and sort this out. You can move on to the next slide. In terms of assessment, one thing that I do on my own physical exams is to first gently but maximally extend the arm at the elbow. Once the arm is straightened at the elbow, you then want to maximally extend the arm at the shoulder so that their arm is comfortably straight out but extended away from the body. At this point, you can visualize and palpate for cords starting in the axilla, so directly underneath the armpit. But again, it's really important not just to focus on the axilla, but to move all the way down the arm to the wrist. You'll see on this lower picture, these black lines highlight areas where cords can be seen. So the axilla are closest to the armpit, upper arm, the antecubital fossa, and then extending down into the forearm. In terms of, you can go to the next slide. In terms of complications, so of course there are a lot of them associated with cording, especially since it goes so frequently undiagnosed. There's the physical and the psychological morbidity. So restricted range of motion, which can be both acute and chronic, that leads to reduced function of the arm or the shoulder. There can be acute and chronic pain associated with cording. The appearance of cords can be really psychologically traumatizing or disconcerting to a lot of patients and very upsetting. There can be nonspecific vascular changes in the affected arm. And of course, there can be anxiety, especially when it comes to some patients questioning whether cording might be a sign of recurrence, for example, or metastases to lymph nodes. From an oncologic standpoint, cording can be really disruptive in that it can obstruct further cancer treatment through the limitation of positioning of the arms for radiation, which is very commonly used for our postoperative patients. So cording really becomes a major issue for limiting someone's range of motion, and they can't get the proper radiation that they need following surgery. You can go to the next slide. So timing of cording in relation to surgery. Most patients who have cording come in with cording following surgery, but we also see patients who come in with cording before we've ever operated. On occasion, for those who've already undergone surgery, you can see these subcutaneous nodules that appear to be connected to the cords. And then, of course, the concern is this a very early recurrence? Are these nodules representing metastatic disease to the lymph nodes? A couple studies actually looked at this and biopsied those nodules. And what they found under the microscope is that the nodules, thankfully, were not metastatic disease, but rather they were due to engorgement of the obstructed lymphatic vessels, so totally unrelated to any sort of malignant cells or malignancy. At this time, there's actually never been a documented cord-related nodule that has proven to be representative of metastatic disease. That being said, if someone comes back and they have these very palpable nodules that weren't there before, and those nodules don't dissipate over time, I think it's totally reasonable to set that patient up for a biopsy to get the reassurance that we're not missing anything. With regards to patients who come in with cording before they ever had surgery, this actually can be a sign of metastasis to the lymph nodes. This is likely due to lymphatic involvement by the actual metastatic disease. The speculation is that sort of this cluster aggregation of cancer cells leads to obstruction in the lymphatic channels that causes elevated pressures, similar to the pressures that we would see following surgical interruption of cords. So the pathophysiological explanation for preoperative cording still remains a hypothesis. But based on my experience in the literature, typically I would always work these up. It's very prudent to consider metastatic spread in making decisions about patient management. So in these cases, we order imaging as warranted, and we would certainly biopsy those suspicious nodules and not just chalk it up to being a sequela of cording. You can go on to the next slide. In terms of management strategies, really physical therapy is the gold standard, and I'm not going to get into details on that because we have an expert on the panel tonight who I know will do a much more thorough job at talking about that than I ever could. A couple of the more novel strategies that I wanted to talk about tonight. One, there was a study recently that looked at what was referred to as operative percutaneous cord disruption with immediate autologous fat grafting. So this is just a lot of surgical vernacular for what the surgeon did is through the skin, he actually took a small needle. So he didn't make any incisions. He rather sort of punctured every centimeter or so along the cord and left these little tiny holes in the cores. The thought is that if you insert these tiny holes, it allows this fibrous band to better stretch, and so it increases range of motion. At the same time, he did liposuction on these patients and then injected some of that fat into the areas surrounding the cording with the hopes that that fat was really protective of additional scar tissue from forming following this needle aponeurosis, or is what it's referred to as. It was a series that only included 18 patients, but in the years following, none of them had recurrence of their cording. So it was very successful, but again, it's still an operation. There's also something referred to as a diamondplasty technique. So if you go on to the next slide, there's a picture of what this diamondplasty actually entails. Do you mind moving forward one slide? There we go. So since these fibrous bands are pretty adherent to the skin above them, what this diamondplasty does, if you look at the picture in the upper left corner, there's an incision that's drawn out, and over that longitudinal incision, you can see these little hash marks, which is where the surgeon would make small cuts. Then under manual tension, it would basically stretch out that incision now with those small cuts, and those cuts would open up into diamonds. The surgeon then took the corners of those diamonds and sutured them together, which maintained that incision in a stretched out position. So if you do this immediately on top of the cording, the thought is that you're sort of surgically giving patients increased range of motion. This study was just done on a few patients. It's a really novel approach. It's certainly not standard of care, but it's just one surgeon's additional approach for something that's become really problematic since we don't have a way of preventing it just yet. You can move on to the next slide. And then, of course, simple reassurance can always be a management strategy, but it's really frustrating for patients. And so usually we like to intervene. And again, that sort of brings us to the physical therapy component of things, which really physical therapists are miracle workers when it comes to cording. So you can go on to the next slide. That is the end of my presentation. I'm happy to answer any questions that have come up or that you may have now.
Thank you, Dr. Rothman. That was fantastic. It's so well presented. We really appreciate that. I know we had just a few questions in the chat, if you could address them. And one of them was, what is considered to be a younger age? They saw that younger age comparison.
Yeah, so unfortunately, those studies were done, that was another meta-analysis where they combined ages across different studies, but typically younger age as defined in these studies was either under the age of 45 or 50.
Okay. I know I had my own question was, when obviously we hear about a lot of lymph nodes removed can give an increase of risk for, cording. Can you just give us a definition of a lot? What's that,
So again, it's sort of hard to quantify because everybody is different. I think that even when it comes back to axillary lymph node dissections, we basically take all the tissue between two nerves and the axillary vessels. And so for some women, that might be a minimum amount of lymph nodes, and for others, it might be much more. So removing 3 lymph nodes from one patient could be the same as removing 10 from the other, sort of depending on their anatomy and how things are structured. So it's hard to say what a lot is because it's all relative. I think the more important thing is, did they have an axillary lymph node dissection where part of that surgery is to really skeletonize the vessels? And by skeletonizing, so when I say skeletonize, I mean kind of really scraping all the tissue away from the vessels in the axilla, which dramatically increases someone's risk of developing cording and lymphedema because we are removing virtually all of the lymphatic channels in those cases.
Okay. We have one that had asked, could you possibly get cording 6 months out from surgery? We hear that connection like right away within, a few weeks.
You can certainly develop it 6 months out. You can develop it a few years out, unfortunately. And you can develop it, if you've had it and then it's resolved either through time or, manual pressure, physical therapy exercises. It could be months later and you might redevelop cording, unfortunately. So yes, it's unfortunately a possibility.
Okay. We have one here from Sandy that's just understanding the location of cording. Could a cording symptom also be felt toward the outside top of the hand near the pinky finger?
That is not a location where I would expect to see it. I suppose I wouldn't rule anything out, but it'd be interesting to know if there was any additional cording through the arm that was sort of in continuity with that. But that's not a spot where I would typically expect to find cording.
Okay. And then there was another one just stating, how is this different from a stage 2 lymphedema?
So
Bernadette.
Lymphedema is more of a global swelling of the arm due to disruption of the lymphatic channels. And that really extends from the shoulder all the way down to the hand. With cording, there's no swelling or increased measurements of the arm circumference. Rather, it's sort of these marionette, these like violin strings that are kind of immediately underneath the skin that don't have any association with the development of lymphedema or arm swelling.
Okay. There's a couple questions that are in the chat that I feel like we might want to save, Erin, for our next speaker. Do you agree with that?
I do.
Because they're talking about race.
Very much. I think they're great for Janet, and she may address them in her presentation.
I agree. Well, thank you, Dr. Rothman. If you don't mind hanging out a little bit, I'm sure if any questions come up, feel free to just answer them right back in the chat, which we always appreciate in case we don't get to any. But thank you for being, versatile and getting on your phone tonight.
Sorry about this. Thank you for having me.
Yeah. All right, Erin, I am going to spotlight our next speaker, which is Janet. And would you like to do her introduction?
I would love to, because Janet came as a recommendation from actually one of our Unite for Her members. She was raving about her and sees Janet as her own physical therapist and was sort of the motivation behind this topic. So we are so thankful that you're here to share with us as an expert in this field. So let me share a little bit about Janet. She received her MS in physical therapy and her DPT from Arcadia University. She started treating lymphedema patients 25 years ago while doing home care. She's lectured everyone from students to faculty at Arcadia and has consulted home care staff on how to manage lymphedema in the home. She became a lymphedema certified therapist while working as director of rehab for Jefferson Home Care. And in 2022, she started working as the manager of cancer rehabilitation for the Esplund Cancer Pavilion, part of Thomas Jefferson University Health System. She currently only treats patients with lymphedema and provides physical therapy for post-cancer treatment, including axillary web syndrome or cording. Janet, thank you so much for spending your evening with us. We're dying to learn some more from the PT side, of course.
Thank you so much for having me. And I really appreciated Dr. Rothman's presentation. I learned quite a bit as well of how they actually do the surgery. So I'm very excited. Axillary web syndrome. I have a little, do you want to pull that up? The PowerPoint, Erin?
I certainly can. Yeah. You
have it ready.
I have it ready.
We know it's there.
Since I had the same problems and I'm on a different system, it's just easier if you do it.
Absolutely. Let me pull up my share screen. Bear with me one moment. There we go. And we'll get to play from start.
So this is just a plug for Jefferson. This is our motto, our mission vision. So you can move on. And then this is my contact information. Okay, so axillary web syndrome or cording. As Dr. Rothman said, it's pain and loss of movement that usually brings people to find out that they have cording. It's loss of function of the upper extremity. It's usually in the axilla, but that's not always where we first see it. Sometimes you see it first in the elbow and then you can trace it back. I have had people that have a little bit of cording that goes down the lateral or anterior, so the side or the front chest wall, but it's in the axilla first. It usually appears within 8 weeks, as you heard. It may rarely up to 2 years. It's reported to be self-limiting, but I don't really agree with that. I think the faster we can get rid of the cording, the more function you're going to have. If you let it go and you think it will just go away, there are then other issues that happen. You start getting shoulder tightness and weakness, and that tightness then goes into a shoulder capsule problem, so that all other motions, it has nothing to do with the cording once that's gone, but then you have what you may have heard as a frozen shoulder, and they're just painful and we don't need to do it. Diagnosis for axillary web is really clinically. It's looking at it, finding it, feeling it, hearing your history, hearing what you say about what it feels like. An x-ray won't show it, an MRI probably won't tell you what it is or what's going on. And it's those visible cords, fibrous bands, armpit, elbow, wrist, chest wall. I have seen cording that goes into the hand a little bit on the pinky side, but it's always connected to one at the wrist, elbow, and armpit. I've never seen it alone, which is just what Dr. Rothman said. Okay, next slide. So a picture, just like you've seen, cords there and there. What I find interesting is it follows the same pathway as nerves. So when we talk about treatment, it's the same as when you have a tight nerve. We do that same stretching. So we give out exercises that are called nerve flosses and glides, and it's just this one would be a median nerve. So it's following that C6, C7 from your neck. It's that same band, so it's easy to see. Okay, we can go to the next picture. And just another one that, and that's the position that you find it in most times. Sometimes you have to move the arm a little higher, or you rotate the arm a little more by bending the elbow and then, doing your little policeman thing. And so you just need to find that, feel it. And then the patient often can point to it or tell you what's going on, and you kind of go, oh, that sounds like cording, along with whatever else is going on in their lives. So next slide. So the standard exercises that you all probably were taught right after surgery is wall slides. So you're standing in front of the wall and you slide your arm up. I'll get back on camera and show you these exactly. But one is you're just sliding your hand up the wall, and then you turn and you slide out to the side as table stretch. So you're away from the table. And you just slide your hand as far out as you can in front, and then you turn to the side and you go out to the side. A corner stretch is kind of what this woman in purple looks like. She's in a doorway, but you can also do it in a corner. So her hands are a little higher than I like about shoulder height, and you just lean in and you get this wonderful pectoralis stretch, the muscle on the front of your chest wall. And I do this myself. I do it in the shower, so it's always in a corner, but I get the front of my chest all warm, and then I stretch, and then I go back in the shower, and it's just a really nice movement. For those of you who are over 40 and maybe younger, there's a movement that's what Steve Martin always did, walk like an Egyptian. So you have your hands together, and I'll show you this. And you're just moving them back and forth, just like we did with that song many years ago. Okay, next slide. So it's important to stay active, recognize symptoms that you do need to see a professional. So pain, loss of movement, just a heaviness in the affected limb, the chest wall, or the armpit. Lymphedema, is separate from cording. Lots of people get lymphedema and have no cording. Lots of people have cording and no lymphedema. And other people come in with the whole gamut of everything's going on. You certainly can have lymphedema of the breast. You can have it of the lateral, the side of your chest wall. And you just can't really say who's going to get what or why it happens. So I put the logos for both the American Physical Therapy Association and the American Occupational Therapy Association. Both PTs and OTs are certified, can become certified lymphedema therapists. Occupational therapists usually focus in on function. So if you're really having trouble with your hands, if you really can't do the activities that you need to do to get through the day, dressing, bathing, feeding, an OT is really wonderful. And then the PTs are more likely to give you painful exercises. That's what we do. We cause pain and suffering. No, we're trained that way. The two mottos are pain and torture, our PTs, or a physical terrorist. I think that's it. Is that the last one, Erin? Oh, no. So typical treatment is stretching, and stretching the joint, stretching the muscles, stretching the arm, but then stretching the cording. So it's tissue massage. There's a fancy term called myofascial release, and that's taking that tissue and stretching it between your fingers. The most wonderful sound for somebody that has cording is a loud pop, and that cord just goes away, and you don't get all of it, and you don't get all of them done at the same time, but it's a wonderful thing. And it seems like the popping happens sooner if we see you sooner. Not that I don't get it from people, but it takes more work. Scar massage is a really deep tissue technique. It's getting in there and strumming like a guitar or doing little E's, but it's very deep. And scar massage, once it's healed, not right away, but once it's healed, really can then decrease the lymphatic congestion that can lead to cording or be associated with cording. The joint mobilization, so that's every joint has a movement that you do, but then there have to be associated movements. So with your shoulder joint, when you lift your arm up, the ball and socket, the ball has to go down, it has to go forward, it has to go back. And when that capsule, and I always think of if you take apart a chicken wing off the bone, there's all this tissue that you see, and that capsule just gets tighter and tighter and tighter. And so joint mobilization is what a physical therapist would do to get that capsule larger and get you moving better. Lots of active exercises and active assisted stretches. So if you want to, that must be it, Erin, right? I think that was my last, yeah. So when you lift your arm up, the ball of your shoulder needs to come down. And if that has been limited by cording, the therapist will do that. Scar massage is, let's see if I can get on the camera, is really just right over the scar doing a deep tissue massage. That's kind of the strumming, kind of a, and then the other stroke is more making ease. And it's not painful, but it's not comfortable. Cording, I need two hands to do, but it's stretching the tissue that way. With my two hands, I would be doing that. So it's pulling it apart. And much more deep tissue. When you're doing lymphedema massage, it's just moving skin. It's very light. It's about an ounce of pressure. That's kind of lymphedema massage. And then scar massage and cording is a much more intense activity. I told you I would show you the wall slide. So I'm going to go to the corner. So you can see me. So the wall side is just going up as far as you can, and then leaning in a little to get a stretch. So that would be the front. And then the side, you would go out to the side and lean in a little. And then my corner stretch is more like this. So your hands are shoulder height. I think you can still see me. And the table stretch is you want to be a little bit away from the table, and you're just going to have your hand go forward as far as you can. And it looks like the wall slide, but when you do it, it really isn't. It feels different. When I talk about myofascial release, when I talk about flossing or nerve glides, I really don't want to show them because they're so individualized. And you really should find a physical therapist to do cording and stretching and frozen shoulder problems. You don't need a lymphedema therapist. Someone who works in a cancer center or is connected to one certainly knows a little more, but any therapist can do the cording. Not everyone can do lymphedema. In fact, you really don't want someone who's not a certified lymphedema therapist doing it. So I think that's all I had prepared. Are there questions that I haven't answered?
There are. We have quite a few in the chat there. Right, Erin?
Yeah, I think going back to some that came up during Dr. Rothman's presentation, just starting with, is there a correlation between working out, light weightlifting, and cording?
If I can start, most of my patients have not started lifting weights when they come in with cording. They're still on the restriction. So I would say no, Dr. Rothman.
I agree with that. I haven't seen that association either.
Can I interrupt?
Absolutely. Yeah.
I'm Janet Wilson. I don't know how to do the chat. I hadn't figured it out. I was a bodybuilder and I've had cording now for 9 years. And unfortunately, it's getting worse, but beside the point. But I find that when I lift and don't have my sleeves on and everything, but when I lift and all, the cording does get worse and the lymphedema also gets worse.
Okay.
Are there restrictions for movement if a person does have cording, but they've gotten a point post surgery that they've been cleared for exercising for light weights? Are there certain things that a patient should be mindful of in terms of lifting?
Not from a surgical standpoint. I don't place restrictions on them at that point, especially since I want to make sure that they're using their arm. I think that is a really important part of sort of the resolution of cording is being able to do exercises and not putting restrictions on range of motion. I haven't seen, unfortunately, any correlation between heavy lifting. I know that someone had just mentioned anecdotally that she unfortunately has experienced that. So it's certainly an interesting thought, and I think something that needs to be researched more. But typically with cording, I encourage lack of restrictions in those cases.
Yeah, question here, Erin. It says, is there any benefit to having a sleeve on when you're exercising with cording? Yeah. You know that, Janet or Dr. Rothman?
We don't recommend sleeves unless you actually have lymphedema. There's no reason to get one. And so most people who just have cording don't need to wear a sleeve.
Great. All right, we'll keep on going, Erin. We have quite a few. There's one from Pam. She said, should a person 25 years scarred tissue have massage to the armpit area? Should a person with 25 years of scar tissue have massage to the armpit area?
My opinion would be absolutely. anything you can do to break it up and make it feel better, yes.
So the 25 years that doesn't mean anything. Okay.
Okay.
Wonderful. Going
It
back to
will just take longer to fix. It's not going to be a quick fix.
okay. I had the question that Michelle was asking, the exercises that you demonstrated, Janet, how often, if a person wanted to start them, how often is there a rep or a number of seconds that they might hold it? Is it something they want to do twice a day? Is there like a standard starting point?
So we usually give out, do 10 reps of a good stretch that you hold for 5 to 10 seconds twice a day. That's what you can fit in most of our lives with kids and work and life. You don't want to burden it so that you don't do it. You want to pick something that you can do that's going to make a difference, that you'll stick to.
Okay.
I know that Amy said that she has frozen shoulders, so some of these exercises are really hard to do. Is there workarounds that you recommend, with that frozen shoulder? Because it sounds like movement is better. Any kind of movement is going to help.
So frozen shoulders often respond well to pulleys, to get a pulley, and but it's really getting those accessory motions that I was talking about. So if you think about the arm going up, the ball of this has to move down. And if that capsule is stuck and it can't move, that's when you run into trouble. So a PT or an OT will stretch that capsule by moving it in all those directions so that when you have to lift, it moves. So I don't know.
So they should definitely consider working with someone to help with some of that manipulation.
Yeah, and a frozen shoulder, you can go to anyone. You don't need to wait on a waiting list for lymphedema treatment.
Okay.
I even know that frozen shoulder has been treated through acupuncture as well. So, there's a variety of ways that you could maybe approach it, not just one magic stretch, and it might be a combination of things.
Yeah. Tracy had a good suggestion for just the wall slides to perhaps put a pillowcase, I guess, or something smooth under the hand to help it slide. Would you recommend that being a safe tool to use?
Yeah, we often do that.
Oh, great.
Yeah. Good.
Yeah. Anne had a great question. How often does cording come back after it has resolved? We may not know. It may not be something that statistically there might be data on, but any thoughts?
I think, unfortunately, because most of the studies are retrospective, meaning the data has already been collected, patients were only followed for a very short period of time, it's really tough to glean the risk of recurrence from that. As we develop more prospective studies that are watching patients in real time, we'll be able to get a better sense. So right now, unfortunately, the data doesn't exist, but we know anecdotally, just through case reports and things like that, that recurrence can occur.
So with that potential risk, is it something that you would recommend someone that has a history might continue to do those exercises, maybe work that into their regular movement routine? Is that something that might be beneficial, just to be a little proactive?
We, before I even operate, I give all my patients a set of exercises that I want them to do post-op day one, as soon as they're ready to do it, to really sort of maintain range of motion. What can be really upsetting is when patients come back thinking that they weren't allowed to use their arm, and suddenly they can't use their arm just due to sort of the restrictions that they've imposed upon themselves. And so we try to be really clear up front that they can do what they're comfortable with. The only restriction I place on patients is really weight for the first few weeks after surgery, because I don't want their incisions to break open. But I always encourage, maintaining range of motion as much as they're comfortable, just to sort of prevent these really horrible issues from occurring. We don't want to be causing problems, trying to do good things. We don't want to make things worse for patients.
I feel like on that same note too, Janice was asking, can she self-massage? I'm curious. I would think yes. Is there any danger of doing it incorrectly?
The only danger from a surgical standpoint is if someone starts self-massage too early. So a lot of times I'll see patients for follow-up and they have a lot of scarring in their breast, whether it's from surgery or radiation. And so what I don't want is someone to start self-massage within a few weeks of surgery because everything is still healing. There's a lot of sutures on the inside. When it comes to cording, the area where the cords are going to be is not an area where I've operated. And so I don't have any problems with them massaging those areas. But when it comes to massaging surgical sites specifically, I would usually ask them to refrain for at least 6 weeks following surgery.
Okay. I think, Erin, we have time for one more question here. I can pull this one up. Joanna was asking, is there anything I can do during radiation to prevent cording or lymphedema?
It's really just what Dr. Rothman said. Keep exercising. Do the active range of motion. To get external rotation, you put your hands behind your neck. To do internal rotation, you reach up for your bra strap. If you can't do it, you can pull with a belt or a pillowcase. So you probably can't see this, but you're kind of, well, anyway, one hand is behind your back and one hand is pulling a pillowcase or a belt up. So those are just gentle stretches, all the ones I showed you that are pretty easy to do, that I would feel comfortable you doing it yourself. The nerve glides and the myofascial and the really intense stretching, I wouldn't have you do without a little supervision. The great part of cording is that you see them once or twice and you're done. It really doesn't take long. And it's it's one of those miracle cures that we do. So.
Good. That's positive. Well, Dr. Rothman and Janet, thank you so much. It was really, we had well over 60 on here at one time. So it definitely is a topic that a lot of our community talk about. And I was sharing even with Erin, and she's like, Sue, when I'm doing cooking, I can't tell you how many people have really struggled and talked about their cording because they were just lifting pots and moving from island to sink. And so it is a topic that our community is always looking for. We appreciate both of you. Thank you.
Thank you so much.
Thank you for having us.
All right.
All right, Erin. Well, I think we have another speaker series under our belt. Thank you all for joining us.
Absolutely. It's been a great night.
Of course, I want to thank our sponsors once again, and I will share our screen. And Erin, you might be able to even share a little bit too about what's upcoming that these wonderful sponsors have been, enabling us to bring each and every month.
And we are so thankful for them. Absolutely. So catch us next week for our virtual hangout Wednesday evening, 5 p.m. Eastern time. We are celebrating Black History Month by connecting and showcasing two of our wellness providers, Rana Walker, who is a yoga provider, Kevin Hubbard, who is a counselor, and they will be taking us through a session. So this is your opportunity to join us if this is a service you haven't tapped into, to learn a little bit about it, about the different techniques, and hopefully this will interest you to maybe use some of those squares if you are an active passport holder. We're also at the end of the month. We have an Ask the Experts. We are bringing back Potty Talk with my lovely coworker, Sarah Murphy, to just ask some common questions about, again, some of those GI issues that we have from some of those medications that we're on, whether it's an acute period chemotherapy regimen or a treatment that someone is on long-term. We know that GI health can be impacted. So we're sort of retouching on that topic again and going over some questions again. So lots of great stuff coming up. Hopefully you will catch us next week and then a little later in February. And maybe for those that are in the Philadelphia area, maybe we will see you at the convention center in just a couple weekends.
Yep, it's coming up quick.
I know it.
I know. Thank you so much. And please remember too, those of you that are on passports or are not on passports, Erin and her team have over 48 cooking demonstrations that they do a year. So they end up doing them about, I guess it's 4 times a month, Erin, that you could jump in on. It does not cost you any of your squares. It is just very joyful, a lot of fun, always learning. So know that you can hop into those just like you're hopping into the speaker series, Ask the Experts and virtual hangouts. And I think that's it, Erin.
Wonderful. Another great night.
All right.